but we can certainly see that she's not going to have enough space. And so just looking at this, it's not going to work. It's not going to fit. So we need to be able to take control and to make more space. And we can derotate that upper first molar. We can expand out the second molars. And in reality, again, I want to be hard on myself because this is something that I think can be better. I actually don't think we've done the best job. The beautiful thing about this is there's not a right or a wrong. There's just different. Okay, so this case is not completely finished. You're going to notice that she's at the very last stages, but we're pretty close to being there. So this patient comes into our practice and she looks similar to her sister. She's a little bit younger than where her sister was when she's got a decent overjet. It's not crazy. She's biting in a slight class 2. Primary canines are about to fall out. You can see the photos here aren't the best. My staff kind of got some blurry pictures, but it's good enough. Now, she's actually lost her teeth earlier than her sister because she just has her lower second primary molars, and on the upper, well, I guess she's at the same stage with this because she still needs to lose 5 primary teeth on the upper. When we look at her x-ray, the teeth all have a clear eruption path, but we can certainly see that she's not going to have enough space when you look at the lower canines because the lower lateral incisors flaring into that canine space already. And so just looking at this, it's not going to work. It's not going to fit. So we need to be able to take control and to make more space. When we look at her facial profile, we don't need to look at the cephalometric. We can see, though, that she has a pretty decent facial profile and that she's actually, facially speaking here, is going to end up probably with a bit more of a dished-in face long-term. Likely her nose and chin are going to keep growing. Her lips don't grow as much. So when I see kind of this full facial balance, but with a more prominent nose and chin at the beginning when they're still young, that usually means to me that their chin and their nose are going to grow more. But let's see if that's actually the case. Yeah, I mean, this is a few years later now in treatment, and you can see the nose has definitely grown a bunch more. Her chin didn't grow tremendously, so it's not so much that she's super dished in, but imagine her chin came further forward by more. You'd look at the Z line here and you'd say, wow, her lips and they're back from her, well, I should say the aesthetic line. That's going to be very noticeable, and you guys are getting a sneak peek at where she's going to be later in treatment, so I guess here it is. You're going to see the same thing as her sister, right? We're going to get her into class 1 occlusion. We're going to work on her overjet. We're going to work on her midlines. We're going to work on her smile aesthetics, all those things, but let's not get ahead of ourselves. Right? She's a narrower arch just like her sister as well, so we're going to need some arch development to make things fit. Now, you'll actually notice, I think the pan is slightly outdated because the canine's in, or maybe we just uploaded the wrong x-ray. Could be that we have the wrong x-ray since we have 2 different charting softwares in our practice. But the main point I want you to take away from this is there's a decent amount of work to do. So let's go to our ClinCheck and see what are all the things we're going to work on. Okay, let's go to ClinCheck number 1. So in this situation, this patient's coming into our practice when she's only 10, whereas her sister didn't actually start treatment until she was closer to 12. When we look at the initial position to the final position, I have a question for you guys. What's her classification? Well, she's similar to her sister. She's slightly class 2. She's not crazy class 2. I mean, we just looked at her face and said, wow, look how prominent her jaw is. And she's a pretty prominent jaw. So she's not super class 2 here, but from a dental perspective, she is a little bit class 2. She has a larger overjet. The difference here, though, is that we're starting her, like her sister's case. Let's go back. She started when she had just her adult teeth. And so when we look at the size difference between her premolar teeth on her upper and her lowers, they're all designed to fit together properly. When we look to her sister, well, now when we evaluate the teeth, look at how she still has her primary second molars. Because she has her primary second molars, I want you to evaluate something. Look at the size difference when you compare the upper primary molars and the lower primary molars. There's a big difference, isn't there? Right, whereas the premolars are almost the same width, maybe slightly different, the primary molars here are significantly different. And that what makes up what we call the leeway space. Right? The leeway space is that the erupting premolar tooth is going to be a little bit smaller on the upper than the primary tooth. But on the lower, it's actually quite a significant amount smaller. On average, it's usually 2.5 millimeters. So what that means is that this extra space that you see here between the difference of the premolar tooth to the primary molar, if that's 2.5 millimeters, well, that means that usually this lower premolar tooth will actually shift forward slightly. So if you are in a situation where a patient is still has their primary teeth for their lower second molars, primary molars, you will often see those teeth shift further forward into more of a class 1 occlusion as they lose those primary teeth. And so, while yes, we need to be aware of the fact that this patient's slightly class 2, it does not say to me, hey, you know what? We should jump in immediately with class 2 elastics like it did with her sister. Instead, how I evaluate this is I say, well, we know we're going to have some anterior posterior changes that are needed, but she's still pretty young. She's only 10 and a half. Her jaw is more prominent than her sister's. And so let's go ahead and start off with not worrying so much about the bite jump and the anterior posterior changes, but let's go ahead and focus first and foremost on creating space and arch development. Because once we go ahead and derotate these teeth and get them in a better spot, we can then instead focus on maybe just doing treatment at nighttime. So you'll see here that this tooth is gray and it doesn't show any movement on it. Because if we actually click to our tools, see where it's hiding here, we want to go ahead and click on the eruption compensation button. So the eruption compensation button, this eruption compensation button is showing us essentially, and you can also just hit E as a short command. It's essentially showing us spots where we're going to catch that erupting tooth in the tray. Think of it like a baseball catcher's mitt is going to catch that erupting tooth as it comes in. Or for any of you Aussies listening, it's the wicket keeper. So you're going to catch that tooth and guide it into place. And so it's just a normal spot in the tray. It's not something that's different plastic or anything that's unique and super special. It's just literally a spot in the tray that's going to catch the erupting tooth and help guide it. So what we focus on in this plan is we're just simply derotating teeth. We're proclining and allowing some arch development and expansion. In terms of hygiene, she's a bit better than her sister, but you can still see all of the food that's stuck in her teeth. So she still has a lot of food stuck in her teeth, don't get me wrong. But it's definitely much better than what you would see present, like with the gingival health than her sister's case. So we still need to have those conversations, but it's not as significant. So in this case here, though, again, I hope you understand the reason why we're focusing more so on the, look at how big this tooth is. Look at how small the premolar is going to be. So we know that the molar on the lower is going to shift forward, and that's why we're not as worried about the class 2 correction, and she's also younger than her sister. And if we went to her C-spine, now the way she was positioned with her x-ray and the sizing of the machine, it wasn't the best. So you can't actually see more than just the inferior of C2 in this situation here, but C2 does not have curvature on it yet. I can tell you without even looking at this patient that she's not at the point yet where she's going through puberty, so we have a lot of time. I'm not worried about the time. Okay. So in terms of derotation of the teeth, we have root tip that needs to happen on these central incisors. So we could certainly go to the table, go to the tooth movements, click here into angulation, and look. And actually, interesting, I didn't realize that. We just went 5 and 5. Huh, never knew that. If you look, check out how the central incisors, even though that looks like there's a lot of root movement, because I would theorize that the roots would be divergent in terms of their position, it's saying here that they have less than 5 degrees of angulation changes. So it is more of a rotational move, which ideally we would probably look to use a rotational sash attachment or a root control sash for the rotation, but we don't here. We just simply stick to using the root control attachment because it seemed like the root movements were more significant. And I actually don't even fully know how that's going to play out, but my expectation, seeing how much rotation there is by having a root control attachment show up, knowing that we don't actually have a whole lot of root movement instead of having a rotational sash, my expectation is we might not get all that full movement. But her sister, remember, in her case, we didn't place any attachments on her centrals. We simply just allowed there to be no attachment whatsoever on that first series. But keep in mind is when we actually look at the tables for how much root movement is happening, we only had 7 degrees and 6 degrees. Whereas her sister gets the attachments on the teeth, but she's got 38 degrees and 26 degrees. But the attachment being the root control attachments is not going to be focused as much on controlling the rotations. It's going to be more on the root angulation, which is what I do see when I look at this. It seems like the roots would move more. But the main takeaway I want you to have from this is that if we had changed out these attachments to a rotation or a root tip sash, I think we probably would have a bit more consistency in how things moved. Regardless, she's young, we've got a lot of series of trays, so it doesn't really matter that much because we know we're going to have more work that we need to do. Let's go ahead and start just by looking at progress photos. Now what you'll notice is you see these progress photos showing up, which, well, she's not finished her first series of trays, don't get me wrong. Essentially what we're doing is because of her poor hygiene, we're actually bringing her in for plaque indicator. And if we don't see it spotless with plaque indicator, we'll often do it again. Or even if it is really good, we might see on our dental monitoring that she's not doing great with her hygiene. And so we brought her back 2 times just to plaque indicate her teeth to show her areas that she could make improvements on so that she knows that we're watching. Because we really want to ensure that she's doing a good job with her hygiene. But at the end of her first series of trays, this is where she's at. So we've got some pretty good derotations. If we look to our molar region, we can see that we've lost our lower second primary molars have been lost. And look at what happens from our original bite position. Just like we expected, we can actually see that our lower molars have slided forward and now our molars are biting nearly in a class 1. Same thing on this side. There's been some natural loss of space from losing that tooth. Now, our canines are still biting in a class 2. And when we lose this upper primary molar, then the upper molar will shift forward slightly because it still is going to be a bigger tooth. The primary tooth will still be bigger than the adult tooth coming in, but, oh, I'm jumping ahead. But we don't necessarily need to worry again about the anterior posterior corrections immediately here. We can give it more time. Let's go ahead and look because we can see a bit better on our actual ClinCheck that even though it looks like these teeth are pretty straight, what do we notice on our ClinCheck? Well, how did we do with derotating these teeth? Better. But this attachment that's on the teeth is not designed for rotational movement. It's actually designed more so for root tip, right? That's why it's called the root tip attachment, root control, I should say, attachment. So we got like 75%, 80% of the movement, but we didn't get perfection. And so we still need more derotation. Now, in this scenario, we decided not to replace the attachment because that would mean an appointment. But sometimes that's also not the best move because let's look at where we actually get after our next series of trays. And from here to here, how much improvement do we get? Well, we get another 30% of what was still left, but are these teeth straight? No, they're not. And even our next series, we're going to start working on some class 2 correction. We're trying to just leave things as is and do this almost with the equivalent of either no attachment, is what you can kind of think of this like, or a really ineffective optimized attachment that hasn't been changed. And even on our next series of trays after that one, what are you going to see? Well, it's 30% better again, but it still needs more rotation. As we go through series of trays after series of trays after series of trays after series of trays, what's the commonality here? Is that, well, it gets a little bit better even if you don't have the right attachments on it. But boy, does it sure take a long time to finish derotating those teeth. So I'm not here to say that you can't get the movements utilizing an optimized attachment or utilizing an optimized attachment that you still even leave on the teeth. The main thing I want you to recognize is that you can, it just takes a lot longer. Whereas if I treated this again from scratch, what I'd likely do differently is, let me go up and modify this plan. If you were simply for the rotational component to put on a rotational sash, that would mean that you'd be positioning an attachment similar to this, probably increase it to be 4 millimeters in width. We'd have to ask them to remove the old attachments that are currently on the tooth. And so you would end up something like this. Is going to be a very consistent attachment to help rotate those teeth and get that final movement done. Or you could have opted to have them place new optimized root control attachments. But the thing that's interesting is, let's go ahead and plop this back in the garbage, is if you want to use Invisalign's optimized attachment on the tooth here, which is this one right here, this hexagonal attachment, and plop it on the tooth. This tooth is marked for attachment restriction. I wonder why that is. Maybe because it has some remaining attachment still on it, the old attachment that was scanned. But normally if you actually drag this and drop it onto the tooth, what's really interesting is you will notice that there's only two types of attachments that you can use for central incisors. You have an optimized root control attachment, and you have an optimized extrusion attachment, which looks just like the one on the lateral here. Those are the only two attachments. I guess this is not extrusion, this is a conventional, but those are the only two attachments that you can place on a central incisor. There is no optimized rotation attachment. So if you want to have rotation, you either need to keep replacing this optimized root control attachment, or you're going to have to make a change and use a conventional attachment yourself. But again, the main thing I want you to see here is that yes, we can keep making it 30% better of what hasn't been corrected each series of aligners. It's just that this is number 2. This is now number 3. Then we've got number 4. And then we've got number 5. Took till number 5 for us to actually get those teeth derotated. Whereas again, I think we could have been much more effective if we did that sooner. Let's go back. So we're talking about how we're waiting for these primary teeth to fall out, but I think it's safe to say that anybody can look at this now and recognize this patient has a large overjet. And so even if the molars on the upper weren't to shift forward, well, we've got a difference between our top and bottom arch. We need to do something about it. We can visually look at this, again, looking at the patient's photos, because we can see this overjet. Because look at the canines. The canines are biting in class 2. So if the canines are biting in class 2, that's going to give us a good indication of what our anterior overjet situation is. So looking at her facial balance, does she need a lot of anterior posterior changes? Well, no, she doesn't. So we could have certainly used elastics. We can also use something like mandibular advancement. And so in the end, what we chose to use is actually the mandibular advancement. And so what you'll see here is that this is the mandibular advancement feature where we have wings that go on our trays. Now, is this going to make her jaw more prominent? Well, yeah, it's going to posture her jaw forward, but it's also going to constrict her maxillary growth because the wing here on the top is pushing against the wing on the bottom. And so there will always be some degree of maxillary growth decrease on the upper arch and mandibular increase. That's how we're correcting this patient to a class 1. No matter what, if it's elastics, if it's a Herbs, if it's a Mara, if it's any class 2 corrector, there will always be some aspect of slowing down the maxillary growth and increasing the mandibular. And so in this scenario here, we can see that this is jumping her jaw further forward. But again, there is some some restriction that's occurring on the upper. So the wings posture her jaw further forward. And ideally, at the end of this series, then, this patient's biting in a class 1 canine. Let's go ahead and take a look, because here's where she's at the beginning of this series. She loses that upper primary molar, which means that normally we'd expect to see the upper molar slightly slide forward. But yet when we actually look at what's happened, utilizing the mandibular advancement feature, she's biting in pretty much the molar position is still very similar, and the mandibular teeth have all moved forward, relatively speaking. Right? They're all interlocking now between the maxillary teeth. So we've got nice intercuspated relationships here, right? That the mandible has come further forward. Now we still have some rotations needed and some extrusions just to close up spaces. So that's what we're going to work on the next series then, is we're just going to tighten up some spaces here, bring those teeth down into full occlusion. That's all just minor detailing at this point. But what's happening in the posterior? Well, she's the same as her sister. Let's go back. You can see this is where she's currently at after utilizing that class 2 correction with the mandibular advancement feature. She's biting now the molars are starting to come in more, but the uppers, so it's not her lowers, but the uppers right here, you don't see the uppers. We need to wait. And we wait. And we wait. And there they are. Right? It takes some time for those upper molars to come in and then fully erupt down into a better position. And so that's the reason after this series of trays that we continue to get more, because this is the one where we're now addressing and adjusting the anterior posterior positioning. With the growth modification, but then let's go ahead and take a look at her actual plan. So here's where she is when she comes back. So she's biting intercuspated, but we don't have the upper teeth. And so at this point, we can just go ahead and, well, there's two things we need to do because we looked at this earlier, how her upper incisors still required a bit more rotation. And then at this point, once they're actually straight, then we go ahead and have her wear her trays just at nighttime. And then this is where she's finally at. With the molars needing a bit more movement, we can go ahead. Oh, and this is just what I've modified actually. So let's go back to this one as the one we accepted, where all we're wanting to do is help control the root position, because what did I not do maybe as well as I could have with her sister? Is when we look at the actual eruption of these teeth, she gets to this point here and we go, you know, how do I feel about the position of that? Let me zoom in. Upper second molar. Is this the best contact that we could possibly have here and here? No, it's not. And so where in her sister's case, I didn't address some derotation and a little bit of arch coordination. In this case, we're going to finish that. So we plop an attachment on, and at this point, she's just wearing her trays at nighttime. So we can go ahead and we can derotate that upper first molar. We can expand out the second molars. And in reality, again, I want to be hard on myself because this is something that I think can be better. I actually don't think we've done the best job of, we could derotate this tooth a little bit more. And if we grab this and derotate this a bit more, we're going to make the contact more broad. Right? Derotate those teeth just a little bit more. That's probably a bit too much. And then we have better, broader contacts that are going to ensure no food traps. And so this is always the debate. I want to be completely honest with you guys. The debate with orthodontics is always, when do you call it? When do you say, you know what, this is great? I would say these cases, both of them, they're very good. They're beyond clinically acceptable. It's now just at the point of figuring out, okay, is this now at the point where we say this is excellent? Is it good? Is it poor? And so should we stop? And to me, that comes down to a conversation that we have with the patients, and if they're growing patients, with their parents. Because as we evaluate these last little changes and we talk to mom and we talk to the kid and she's just wearing her trays at nighttime, they're both okay to continue on. And so from my perspective here, if they're okay to continue on and I can make things better, then that's kind of my goals. I'm not here to say that it'd be wrong to stop sooner. I'm also not here to say that my cases always turn out with perfection, because they don't. But I'm here just to give you perspective as to how we approach these cases, to see that, well, all we need to finish doing is a little bit more arch development, bring those teeth down, help guide them into place. So some nighttime trays with a few attachments on them isn't that much work relative to what we've already put in. So again, what would I change if I did this again? I would change some of the attachments on the central incisors from the beginning. I don't think I made a mistake in waiting on the anterior posterior adjustments, because you give it a bit more time and then do it later. In terms of finishing things off by not concluding the case until we have those second molars in, I like the fact that we did it that way, because I can do a bit better job of dialing in the occlusion than I did with the sister. But all in all, again, we look at both of these patients at the end of treatment here. Let me go back to their photos of this patient, and we see, let me go to when she has, I was going to say a better smile, but she hasn't smiled big for a few photos here. But you look at a position like this, and you look at the function of the occlusion, and how rewarding is it to have a kid start off here and be able to make all those changes to modify their experience in school and improve some of the social issues when it comes to bullying, to avoid them in this kid's case compared to her sister entirely, because we jumped in a little bit earlier and we addressed this sooner. Now, I'm not saying that we should have, that we made the wrong move in the first kid's case. She had a lot of teeth that were about to fall out. Really, we were lucky because sister number 2, she had more teeth out at a younger age, and so that made things more straightforward in terms of deciding whether we should start or not. But we absolutely can finish her in class 1. We can derotate those teeth. We can fix the overjet, whether we use elastics like we did in her sister's case, or whether we use the mandibular advancement feature like we did in this case, the beautiful thing about this is there's not a right or a wrong. There's just different. And as long as we're doing what's right by our patients by treating them to the highest standards, I'm not here to say use mandibular advancement feature or don't. I'm not here to say do finish getting those second molars into position or don't and go longer, or vice versa. There's certain things we need to do. We need to aim for perfection. We need to fix the overjet. Doesn't matter how we're doing it. We just got to do it. We got to aim to put them in class 1 occlusion. We got to try and have their facial midlines balanced as best we can. We need to fix their overjet. We need to fix their torque. We need to fix their deep bite if they have it. Those are all kind of the considerations. But the reason I picked these 2 cases is because I knew I treated them both slightly differently, and that I learned from some of the things that I would do differently nowadays. So I hope that gives that perspective. In terms of the reason why I do this, I think many of you know already, but it's because I love teaching general dentists how to treat to a higher standard. We absolutely can be doing complex cases, and we can be doing them really well. We have our clearly aligned and clearly select opportunities for doctors. Clearly Aligned is the education company that covers all the education, whether it's this free stuff, whether it's courses that are in person like I'm doing currently while you're watching this in Sydney as I'm lecturing on foundational systems. I think we have about 55 doctors who are signed up for that, or just whatever it is. It's the baseline education is through our clearly aligned community. When it comes to if you want to take your practice to the next level and receive more support, receive discounts with your Invisalign cases, receive the business insights into how we approach things, get access to every single one of our online courses, get support with 10 ClinChecks. So ideally with those 10 ClinChecks alone, you're going to be doing an extra 10 cases that were normally outside your comfort zone, but with us supporting you and helping make you feel comfortable in the plans, which means if you're billing even $5,000 per case, you should be billing an extra $50,000 per year. Doctors in our community save over $110,000, or sorry, make an extra $110,000 in their first year just from doing extra cases because we're giving them the support. And so that's my goal, is to change the landscape of orthodontics in terms of how we do it as general dentists, to do it to a higher standard, but also to make it very profitable and enjoyable. Because the amazing thing is that even though now for you guys, you're watching this lecture, for me, I'm lecturing in Sydney at the same time, my practice is also still running. So our staff started a number of cases today with me being across the world because I don't physically have to be in person to be doing all these things. That's the awesome part of it, is that as you scale and you grow and you get your team more involved, the only area of dentistry where you physically don't have to be doing something in the patient's mouth to be making money, other than, of course, the business side of just owning the business. But it's way different than placing implants, because you can only work as fast as your hands can place them. And so with orthodontics, you don't have that same limitation.